Hello, everyone. I'm Dr. Georges Benjamin, and I'm chairing the Committee for the Analysis to Enhance the Effectiveness of the Federal Quarantine Station Network based on lessons from the COVID-19 pandemic. Because this is a public session, I wanted to welcome everyone to this open session of our meeting. And I want to note that this is open, on the record information gathering session. That is, the committee is in the process of assembling materials that it will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask everyone here today to be mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. This is the second session of the third meeting of approximately 5 planned full committee meetings. Some of these meetings may include public sessions that we have had the opportunity to hear from experts in the field. The committee will deliberate thoroughly before writing its draft report. And moreover, once the draft report is written, it must go through a rigorous review by experts who are anonymous to the committee, and the committee must respond to this review with appropriate revisions that adequately satisfy the Academy's Report Review Committee and the chair of the National Research Council before it is considered an NRC report. The expected report release is around May of 2022, and further information on the study, including future meetings, can be found on the project website. Now, this open session today provides an opportunity to gain international perspectives as well as the private industry, including cruise and airline industries. Will also help the committee better understand some of the legal authorities pertinent to quarantine measures. Now, during the Q&A sessions and discussion, the committee questions and comments will take priority. The public can submit comments to the study email address listed on the project website. Parts of this meeting is being recorded. It is now my pleasure to introduce Dr. Kara Leader and Dr. Alan Chung, who will discuss their perspective on COVID-19 in Australia.
Thanks very much, and thanks for the opportunity. I'm just going to share my slides. So perhaps I might just throw over to Karen and let you introduce yourself.
Hi, my name is Professor Karen Leader. I am an infectious disease physician, and I am head of infectious disease epidemiology in the School of Public Health at Monash University in Melbourne, Australia.
And I'm Alan Cheng. I'm also a professor in the School of Public Health and Preventive Medicine with Karen. I have a number of roles that are relevant to quarantine. I was Victorian Deputy Chief Health Officer, so the Chief Health Officer for my state of about 6 million people. My hospital, which is the Alfred Hospital, also runs part of the quarantine program in Victoria, and also sit on the Western Australian Quarantine Advisory Panel, so the advisory panel for another state's quarantine program. In Australia, it's traditional to start with an acknowledgement of country for the traditional owners of the lands on which I'm on. For me, that's and I think for Karen as well, is the Bunurong people of the Kulin Nation. So just in obviously the context of COVID-19 control, border measures being part of one suite of measures broadly. These are border measures, public health and social measures, and then the domestic test, trace, isolate and quarantine program, and obviously vaccination. And with the original strains that we had in 2020, obviously we didn't have vaccination at that time, but we were able to control these with the other available tools. But with the onset of Delta and now Omicron, we're needing to rely more on vaccination. And really just to say that these tools were employed relatively well, and we had a measure of control in Australia for quite some time, but we have been challenged by Omicron, as has the rest of the world. And This is just to say that just things in the last couple of weeks have not gone quite so well compared to the control that we had before. So border measures, I guess, just putting that in context, is that there's a number of measures in there, quarantine, managed isolation quarantine being one of those, but obviously there are other measures that can reduce the incursion of COVID across the border. Obviously, closing the border altogether, either partially or completely. And I've got a slide to describe some of the policies taken in Australia. There is the home quarantine rather than managed quarantine, and then some of the other measures that actually have we felt have been quite effective: pre-departure testing, post-arrival testing, and then some in-flight infection control, and then the management of aircrew and their screening. And these were some of the measures taken at the international border in Australia to reduce the incursion of cases. These have mainly been border closures to non-residents and non-Australian citizens, and travel warnings for Australians going overseas. But at times there have been border closures even to Australian citizens, at least for numbers of weeks. At the present time, the borders, at least in Victoria and New South Wales, the two most populous states in Australia, are relatively open, so that there is essentially no quarantine for vaccinated incoming arrivals, but unvaccinated incoming arrivals still required quarantine. So managed quarantine in Australia has mostly been hotel quarantine in most jurisdictions. Where there have been facilities that are suitable, they have been repurposed for quarantine. An example of this is the Howard Springs mining facility, which has its advantages and disadvantages, and I'll go into that in a little moment. That's in the Northern Territory, has a capacity of about 2,000, can house about 2,000 incoming arrivals. More recently, there's risk-stratified quarantine, so home quarantine for vaccinated and hotel quarantine for unvaccinated. We have been conscious that there are a number of cohorts where slightly different quarantine or bespoke solutions might be required for fruit pickers and students, and probably a bit more controversially and topically, sports people as well. And this would be include film industry people, for example. And then also just noting that there is an overlap between international arrivals, which is our topic today, but also domestic quarantine. So the hospital I work at, the Alfred Hospital, operates 2 hotels. At one stage it was 3 hotels, one for isolation, and that was this health hotel model, and then one for people in quarantine, so contacts and international arrivals that had complex medical needs, so that we could provide their health needs that are not related to COVID while in quarantine, where they might become positive for COVID. There's also been the need for frontline worker accommodation. So this is quarantine for people, quarantine or isolation for healthcare workers who otherwise may not be able to quarantine safely at home. And there's also the need for secure housing. So this would include people with mental illness or security concerns where they need to be housed and have quarantine or isolation. This does have a failure rate. So in year to 2021, so the year of 2020, and again, this is before vaccination and before we were as good as quite so knowledgeable about COVID as we are maybe now. There had been 6 failures reported from 3,000 active cases in 194,000 returned travellers. Over the same time, New Zealand had 7 cases of infections in staff, or from 514 active cases in 96,000 travellers. So you can see those ratios, and that was when incoming arrivals, the proportion positive was sort of in the order of 0.5 to 1%. However, these incursions had major consequences. So this is the Victorian second wave, and on the right, the genomics. You can see the yellow dots are incoming arrivals, the black dots are cases that have occurred in Victoria, and you can see even the family of 4 at the Ridges Hotel, and then it spread to staff, and then that was constituted our second wave. And Victoria, unfortunately, was the only state to see a major wave in the second half of 2022 with about 20,000 cases. In terms of quarantine, I guess we see this as not just the sort of the protections and the housing, but also sort of the context of it. So that there needs to be underpinning principles to this, a legislative framework, which is slightly complex in Australia because the actual crossing of the border is a Commonwealth responsibility or federal government responsibility, whereas the operation of quarantine facilities is a jurisdictional responsibility. There are sort of the strategic factors. Obviously, the nature of quarantine has changed over time, and that strategic planning has needed to be reconsidered a number of times. There's obviously looking after the people in the as residents and making sure that their needs are met, and then sort of the organisational factors, managing stakeholders and the expectations of people, and then finally the actual hierarchy of controls to make sure that everyone is safe. And this has been talked about in many contexts, obviously, and this is some of the hazard reduction measures that were taken in Victoria. But again, just making the point that it's less about, or it is to some extent, what's in these, what the elements are, but also the organisational factors that are important for governance and management and quality systems to make sure that they actually happen. In terms of the Howard Springs facility, unfortunately, I don't have pictures of this, but my review team in March of last year visited this, and they felt that it was more a reference standard for quarantine facilities. They have not had an incursion outside of infection of a staff member in their facility, just noting that their facilities are slightly smaller than that of other jurisdictions, and it was a pre-existing facility, so it wasn't designed with this in mind. But it did turn out to be probably quite a good facility. It's in tropical Australia, and so obviously there are things that can be done there that you can't do in the colder climates of southern Australia. And one of the limitations, for example, is that it's basically set up for single men, being a mining camp, or at least single adult occupants, and there wasn't really facilities designed for families. But despite all these limitations, it is probably a useful starting point for considering purpose-built quarantine facilities. So I did a report for my state government last year where we considered potential future models of quarantine, and we had these 3 down. So continuing the existing quarantine system, having some sort of hybrid model where there were bespoke arrangements for different types of cohorts, and then the third option being purpose-built quarantine facilities. So I won't go through all of this, but clearly there were advantages and disadvantages of each of these. And the decision was made to work up a business case first, and then to proceed with the construction of the Victorian quarantine hub, which is well under construction and expected to open in February or March. And in this business case, there was a lot of consideration about not only the design and the cost of such facilities, but also what else that might be used for other than quarantine, recognising that there may be times where there is not a need for quarantine. This was negotiated with the Commonwealth Government, and the arrangement is that the federal government is building these facilities, but the state will operate these and provide the workforce. At this stage, the intention is, and just recognising the changing environment that we're in, that it will probably have a fairly limited capacity of 500 to 1,000 residents, although the plans are that it could be scalable up to 3,000 residents as required. So I might stop there, and I'll send these through to you, but just a number of links that might be helpful for the committee's deliberation. There's the plans for the quarantine hub, the report that I wrote in March last year about the options for quarantine, the project for this Mickleham facility. And there are also two reports. The first is the National Review of Hotel Quarantine that was conducted now a couple of years ago, that was sent to National Cabinet. And then Jane Halton, the senior bureaucrat, has revisited that, and that second report is nearing completion, and I expect that will be made public soon. So I might stop at that point. Perhaps I'll just give Karen a chance to add to anything I might have missed there.
No, thanks, Alan. I think you've given a great overview. Perhaps I'll just take 1 minute to summarise and give my my perspective. I think Australia, being an island, is in a luxurious position of having choices about closing borders that not everybody has. And I think through 2020 in particular, when we were learning about the virus, there was a safety in keeping our borders closed and having a hotel quarantine arrangement for people who did come into the country. As Alan said, there was some leakage from our hotel quarantine system into of positive cases into the community, and that itself had a significant impact, particularly here in Victoria. But still, compared to the global coronavirus wave, we were relatively spared, and so we kept that model through 2021. And the big aim was to keep our borders closed until we were well enough vaccinated that we'd be protected, and particularly our healthcare system would be protected from cases, but just as we were getting to the point of being well vaccinated, and in Australia we are over 90% double dosed and moving towards triple dose vaccination now. We were just ready to open up when Omicron hit, and I think there's nothing that can keep Omicron out, and any cases that do come in are just so infectious that you're going to get big waves. So we've learnt a lot, and I think we had a very clear strategy of trying to keep coronavirus out for some time, with a vision that it was until other measures could be put in place. And we have had fewer per capita deaths and other things than other places. But now we have one of the highest per capita infection rates of anywhere in the world since we have started to open our borders and since Omicron has hit.
All right, thank you. Committee members, questions? Ed, Michelle, and then Lonnie.
Thank you both very much. Outstanding. I guess a question I would have is, I should know this off the top of my head, but how'd you all do in the 1918 flu? I also remember you were very, very low for a long time period, and then in 20 or something, you had your flare. What's your history of how Australia handled the 1918 flu?
Yeah, it was a slightly unhappy history. So I understand that we didn't get affected by the first wave, and obviously that was. Sorry, and
everybody mute their phones, please.
I'm sorry. So I understand that. I'm just trying to remember, but I think we weren't affected in the initial wave, and obviously the seasons are out of sync between the northern and southern hemispheres. But once it did come, there was mass panic among governments, and all the borders, internal borders, were shut. And that was actually the last time that internal borders were shut until for 100 years until this one. And I think there wasn't quite the coordination between jurisdictions that there is obviously in this pandemic.
Thank you, Michelle.
Thank you, Alan and Karen, for that impressive review and description of how Australia tackled the pandemic. Question, did you feel as if you were building this framework in isolation? Did you have discussions? Did you have interactions with the US CDC? Do you think, or other global health entities? Do you see a way forward that it might be better collaborations? Or did you have, fine.
Look, I think particularly at the beginning of the pandemic, we were closely monitoring what other countries were doing, but not actually, I don't think there was a lot of interaction with other countries, apart from New Zealand, which sit on a lot of our advisory committees that we often have a representative from New Zealand. I think we were looking a lot to a lot of the Asian countries, so Hong Kong and Singapore in particular, and then and China as well, and really, informed by their, they had a lot of systems in place already, informed by their experience with SARS in 2003. So there wasn't a lot of formal discussion, but there was sort of a lot of keeping an eye on what other people were doing. I don't know, Karen, if you can add to that.
Look, Alan sat on a lot of the committees, so would know about the formal and informal connections more than I would. But, as I say, we had this policy, to shut down hard and fast, I guess, and we're pretty unique in being able to do that. So, there's not all that many other places. Well, there's no other places that are big islands like us, that, with our population that can manage it the same way. I wasn't aware of what international collaborations there were or not, or discussions.
Thank you.
Lonnie.
Yeah, thanks to both of you. It's a very informative presentation. We appreciate it. One thing you didn't touch on and be interested in is communications. How do you communicate between federal and state personnel, but especially between yourselves and the public, and realizing you have a strong safety culture, but how do you keep that trust up and your communication strategy, both internal, but especially external?
Yeah, so internally, there's a well-developed system of committees, and I guess it's probably not completely dissimilar to how it is in the United States. So we have the Australian Health Protection Principal Committee, which is made up of all the chief health officers in Australia. I guess that helps to have 8 of them rather than 50 of them, but and they meet, almost daily around this sort of time. And then there's a lot of interaction between states to say, how are you setting things up, and what can we learn from you? There's a bit of coordination between the states. The slight difference is that Howard Springs facility in the Northern Territory, because the territory is one is small, but 2 as a territory is actually operated by the Commonwealth government, and that's the sort of the one difference to other quarantine facilities. In terms of trust with the public, I think that has been quite a challenge, and particularly that often there's a fair bit of it happening in, with a focus on the mistakes, and then obviously there's the entire Victorian second wave was the result of an error in the hotel quarantine program. So I think there's 2 stakeholders there. There's the broader public, and to make sure that they have confidence that that the quarantine program is safe and is effective. And then there's obviously the incoming residents, and then trying to make sure that they know what's about to come, and being prepared for the challenge of 14 days in being held in a hotel. And I think both of those have been challenges to some extent, and things that we could certainly learn from. But
I might just add that Ellen alluded to the fact that we've had internally closed borders, that the individual states, or I guess there has been some tensions, if you like, between the states and federal decision making, and each state has made its own decisions on which borders they'll have open to which other states. And right now we still have Western Australia, so one of our states closed with closed borders, whereas the other states have opened, but quite recently, and at times we had some interstate borders open and not others, and that's been. So the communications have been difficult and changing, and I think one of the things for the public is that people couldn't rely on domestic travel, let alone international travel, as being static, and potentially got stuck on holidays or on business trips because things would change overnight. We had a very low risk tolerance, and with only 1 or 2 cases in one state, when another state had no cases, borders would slam shut.
Interesting. Stephen.
Yes, thanks for terrific presentations. You mentioned that for vaccinated individuals, you're allowing home quarantine. I'm wondering if you can talk to us about how that is being handled. Is it voluntary? Is it enforced? How you're monitoring home quarantine and how you're communicating with those individuals during that time period?
Yeah, so it varies between different states. Actually, at the moment, at least in Victoria, there is no quarantine for vaccinated international arrivals, but there was this period where they were required to have home quarantine for probably about a month or two, going into, and that finished probably in mid-November. So in terms of how that was managed, basically they were advised of their requirements as they crossed the border. There was a mandatory requirement for testing on at various points in that quarantine journey. I think it was the first day, day 6 and day 13 from memory. In general, at the start, there was some random compliance checking. But as the numbers increased, that didn't become so feasible, and the compliance with testing and quarantine probably was somewhat dubious. In Western Australia, so this is the state that still has a zero tolerance policy for COVID. They have used apps. So there's what's called a Good to Go app, where they can check on people through that app, and people that are arriving are required to put that on their phone, and then they, when they get a ping, they and I need to take a photo of themselves, and the photo is GPS tagged and so on. I think that's suitable for at least a group of people, but there are people that don't have mobile phones, and the other sort of issues that can raise. So that has mainly been used in selected circumstances, and I'm not sure about how useful that will be in a sort of a large number of people. But I think that's probably most of those aspects.
Lonnie, did you get your questions answered?
Yes, thanks.
Oh, yeah. Jason?
Yeah, Ellen, I thank you and Karen for the wonderful presentation. I was actually going to follow up on the use of digital contact tracing, which you alluded to, that in some cases you have this Good to Go app, and are there other things that you're using, and how widely used are they for digital contact tracing?
Yeah, so in my report we did look at a little bit of that. I mean, I think all of them have have challenges. There's always a group of people that don't have that option available to them because they don't have a mobile phone or good internet connections or whatever. There are other groups that English is not a first language, and the app is not available to everyone for that reason. And then I think there's sort of the issues about we didn't go down the pathway of GPS tracking of people and so on, but other countries have, Singapore and Hong Kong, SAR. In general, they don't stop people coming to the house. People can be in home quarantine, can be sort of compliant with staying there, but they can have a party and you can't quite tell easily. So I think they are useful adjuncts, but there needs to be solutions that are independent of that as well.
Okay, so go ahead. Sorry.
I was just going to add. I think we didn't go down that path for a lot of reasons, but it's the reason that we did set up the majority of our quarantine was hotel quarantine, when we were really at a point that we were, we had very low risk tolerance for incursions. A lot of the debate that we had, that I'm sure was in Alan's report, was the remoteness of certain facilities obviously means more difficulties in rapidly getting people to hospital care if they need it, versus the hotel quarantine that we had here in Melbourne and in some other states, which were, downtown hotels that are usually used for international travellers and were empty because we weren't letting any in. So they were, it was a great solution, but with risks of incursions because, the workers in those hotels still go home, go home to their families at the end of their shifts, etc. So we relied much more on trying to cohort the people than to, the home quarantine was not a big part of what we did. And I think that's why we didn't move down that app route any further. It wasn't the main way we managed things.
Any use of telehealth to monitor people during quarantine, or to monitor people that's under isolation? Any use of telehealth technology? Because you mentioned remoteness.
Yeah, so this was mainly for even in people in hotel quarantine, to reduce the contact that people had. So they'd be contacted by phone, by video, and then I think some quarantine systems. So I know Howard Springs had a remote monitoring where people could wear an arm bracelet, and it would take their pulse and temperature and transmit that. So it certainly was that capacity in some facilities anyway.
Thank you.
Thank you. It's had this hand raised. I don't know, and put it down. Did you still need to ask a question?
No, it was answered before. Thank you.
All right, thank you. Anna?
Thank you also for your great presentation. So these policies that you put in place restricting travel, did they differ at all for individuals from Australia? In other words, the quarantine was set up for citizens of the country, and were there any differences in terms of types of travelers? So I'm just wondering in terms of how the country reacted culturally. Was there a cry for "this is wonderful, we're glad you're doing this," or was it somewhat politically charged? I guess what I'm trying to ask you, but thank you for your presentation.
Look, I think everything is politically charged to do with COVID, probably more so in your country than my country. But I think that, so primarily these were for returning Australian citizens or permanent residents, and then, families of Australian citizens and so on. And that was the sort of the policy at the border, that only Australian citizens could come home, and we wouldn't permit non-Australians to come in. As time went on, there was clearly a need to open up the border to non-citizens as well, and that obviously has changed over time. terms of the political support for it, I think in general, the public are broadly supportive of a quarantine program. I think as time went on, it became, the hardships that posed for, families that were split up, or, people that were overseas and couldn't get a place in the program. Sort of that became more and more of an issue. And then, you can't have your French parent over to visit their grandchildren for several years because they're French and don't have Australian citizenship. Then in terms of others, it was felt that having sort of one model of quarantine was probably optimal, but there was consideration for those for bespoke solutions for those economic cohorts that I mentioned during the presentation. So students, fruit pickers, and agricultural workers, and then sports people. And so, for example, the Australian Open last year had a bespoke arrangement where they were in a hotel quarantine program, but were allowed out to practice in the lead up to the tournament. And there had to be a lot of special arrangements to make sure that that was conducted safely. So yeah, there was a mix of models, but primarily sort of a single model was probably administratively easier to manage.
I don't know if Stephen, you have your hand up. Was that you?
Yeah, I have another question.
Okay.
I'm wondering if you can talk a little bit about the nuts and bolts logistics of this. Was the traveler themselves the ones that booked the quarantine hotel, or were they assigned? If I remember correctly, there were different levels of hotels. There were sort of the more upscale hotels you could go to, and there were more standard ones that you could go to. And then the other question was, how did the state know, who was coming? Because this, unless it was through booking the hotel, because this, it was the federal government that was, handling the border itself.
Yeah, so each person could go to, say, I want to go to Melbourne or Sydney, and then they would book a program through a central system, and then the state would allocate a place for them. There's actually only one. It was a bit of a chance as to which hotel you were going to get, so there wasn't different tiers of hotel, and the incoming passenger, there was a user pay system, so they did have to pay for that themselves. Obviously, the recovery of that cost is a little bit variable. People not giving their correct contact information at the end and skipping out without paying the bill. That certainly did occur, but it was something managed through a centralized system.
Just to add to that, I mean that it was quite a limited program. There was quotas on how many people were allowed to come in. So it's not that everyone could come in. There were special arrangements for people needed to apply to get here, and that's how the control I guess was kept. It wasn't that it was a free for all, that anyone who wanted to come was able to.
So I think the capacity at its biggest probably was about, I certainly know I think New South Wales, there are about 6,000 places, and in Victoria about 3,000, and then probably the other states would contribute a number of thousand when they were open. And that's for 14 days of quarantine, so you can sort of do the maths and work out how many people per day. So that's a relatively small number of people.
Thank you. Jason, did you have another question? If that's so, this is the last question.
Oh, very quick question. I was curious that states and states could close borders with each other. So the federal government says it's okay to do that? If it says, I'm going to close my border with you because you have 2 cases. How does that work in terms of your constitution?
So constitutionally, internal borders are a matter for jurisdictional governments. In fact, public health actually is a jurisdictional responsibility as well. So, and that's a very long and painful history of federal-state relations in Australia, which I won't go into. But yes, it certainly the power to close borders rests with, in emergency times, rests with, like in Victoria, the chief health officer then. But obviously each state has to go through a process of, working out whether it's a proportionate measure. So, Western Australia have had it closed because they have felt that their borders closed because they have felt that, that is proportionate in their context. But New South Wales, for example, have generally had borders open except to Victoria during, when there's been some very high risks. So unfortunately, each state has had a slightly different attitude to it. These are coordinated. So in sort of the Australian governance system, there's a national cabinet at the moment, which is made of the first ministers from each jurisdiction and the Prime Minister of Australia, and a lot of these sort of discussions occur at that level, and as well as the AHPPC being chief health officers at each jurisdiction and other interactions at other levels as well.
Again, I just want to.
Sorry, just to finish that, it is pretty challenging to close borders. So, for example, between Victoria and New South Wales, there's 13 million combined people between them. A lot of them live along the border, so have to cross fairly regularly. And there are, I think, 87 different border crossings. So to close each of those is obviously pretty challenging.
Yeah, but we're really behind the time. Michelle, you go ahead and ask your question, but this has got to be the last one. You're muted.
Quick question. Since science was such a moving target, how did you effectively do communication or deal with misinformation in social media?
That's, I think, a challenge as in our country as it is in yours. I think, so for example, there was daily press conferences from most chief health officers and often with politicians as part of that. And that became a bit of a fixture on television in 2020 and 21 at least. Range of official websites, communications from the Chief Medical Officer of Australia, and but I think clearly it is a pretty challenging area.
Listen, thank you all very much. You're certainly welcome to listen in to the rest of this open part of the meeting. So I do need to introduce the next speakers in our session, where we're going to discuss the legal and regulatory considerations of border migration, or border mitigation, sorry. So I want to introduce Steve Solomon, who's the Principal Legal Officer at the World Health Organization, Stephen Hoffman, who's Director of the Global Strategy Lab, Dalala, who's Distinguished Chair in Global Governance and Legal Epidemiology at York University and the Scientific Director at the CIHR Institute of Population and Public Health, and is it Mathu Para, who's the Associate Director of the Global Strategy Lab. And I think, Stephen, you're up.
Thanks. Thanks very much. Thanks for the opportunity to speak to the committee. I want to especially thank Larry, Larry Gostin, who helped me with kind of what you want to know about, which I understand it is sort of what the provisions of the international health regulations, this international instrument, which I'll give a brief background are, involving travel and border security and quarantine are, talk about issues of compliance and talk about sort of legal powers and gaps. So thank you, Larry, for that. I'll mention a couple of things that'll be, I hope, interesting to you, including the emergency committee. And I see that Marty Citron is here. He can give you chapter and verse on the emergency committee as well. But I understand I have about 10 minutes in trying to summarize the international health regulations in about 10 minutes, which has 66 articles, 9 annexes, and 2 appendices, is sort of like trying to summarize the US tax code when it comes to withholding and deductions in 10 minutes. It's basically impossible. But I want to give you, I'll speak a little bit about what the IHRs are. I'm not sure how sort of familiar and everyone is with WHO as an international institution and how they came about. A little bit about that, because I think it's important to understand what it means to have a legally binding international instrument and what it means when WHO issues recommendations under it that bear on issues you're interested in, especially travel. So if that sounds okay, I'll proceed in that manner. I don't have slides, but I will want to share my screen just to sort of illustrate the complexity of the IHR and then to discuss all of these things in light of a headline from today, actually. Let me see if I can share my screen. I think I can. All right, so this is a table which shows the articles which bear on, first column, borders, the articles, I said there were 66, which bear on quarantine, and the articles which bear on travel.
Sorry, Dr. Solomon, we're not able to see your screen if you're sharing already.
How's that? Can you see that?
Oh, yep. Yeah, now we got it.
Yeah, okay. So I don't expect anyone to actually read this, and it's not even yet complete, so I can't offer you until it does. This is a rough estimation. Just to give you a sense that this is an area where it's good that the US and every other country has an authority which is charged with following this. And that's your national focal point or national authority, which deals with this and which engages with WHO. And there's actually a 724/365 system for engaging with WHO on this. And then I wanted to share with you this article from just today. Goes right to the point about travel restrictions. And then I was listening to the previous discussion about quarantine, and I'll get into some of what the big picture things that you may be interested in that the IHR does with that. Let me see if I can show this with a share. So can you see this? WHO recommends nations lift or ease COVID-19 related travel bans. Is that visible to you?
Yeah.
Yes.
Good. Okay. Well, this comes out of what I mentioned with respect to Marty Citrin, the emergency committee, because there's a body of international independent experts that are gathered that make recommendations to the Director General in the case of a public health emergency of international concern. And those recommendations often deal with issues of travel. And what those recommendations are and aren't is important. And this goes back to what the IHRs are. So the international health regulations are a treaty. They bind, in this case, 196 countries under international law. And they did so essentially all at once in 2007. All countries of the world, 196, were bound by the international health regulations. That's very unusual in international law. International law and treaties, as we commonly think of them, grow one by one, state by states opt in to international treaties, whether it's the climate accords or whether it's the tobacco convention. The IHR is different. There's this very special mechanism under the WHO Constitution, which is our founding document. We're different from the UN. We're not the UN. We're part of the UN system. We're a different international organization. Our Constitution, written in 1946, provides this very special power to member states meeting in the World Health Assembly to agree on regulations to address the international spread of disease, among other things, to create regulations that will be binding on all countries all at once unless they opt out. That's what the IHR 2005 is. And they deal with these issues that you are concerned with, as you've seen from that table. I am not going to go through all of those articles, but I'm going to go over some key ones, just three, because actually it occurred to me when you were here, when you were listening, the previous presenters, that these might be of interest to you. And then I'm going to speak briefly about the emergency committee and what it means when it makes recommendations through the Director General. So the three sort of articles, and if I don't know if you have the instrument in front of you, but I'll read very briefly from them so you understand what this international legislation is, because the international health regulations are international legislation. The countries got together and hammered these things out. So these are products of compromise, just like domestic legislation. But there are three, I think, key articles that you'll be interested in with respect to travelers. The first one, the most basic overarching one, is Article 3 of the IHRs, paragraph 1, which says that the regulation shall be implemented with full respect for the dignity, human rights, and fundamental freedom of persons. And then that's sort of the chapeau, the introduction, if you will, to Article 32, which is a relatively short article on the treatment of travelers. And that article says that in implementing these regulations, state parties shall treat travelers with respect for their dignity, human rights, and fundamental freedoms, and minimize any discomfort or distress associated with such measures. Very sort of broad obligation there with respect to the sovereign and travelers are defined. And then there's Article 40 with respect to charges for international travelers. And I think particularly if our speakers from the last session are on, they'll be interested in this because this one has been a source of some particular interest because it deals with, Article 40 deals with charges for health measures regarding travelers. And that's a much longer article and it's somewhat complex. But someone asked a question about what are the nuts and bolts of this? Who pays for the hotel, assuming that people don't jump the bill? What this article, Article 40, provides that except for travelers seeking temporary or permanent residence, no charge shall be made by a state party pursuant to these regulations for the following measures, including appropriate isolation or quarantine requirements of travelers. I'll repeat that. No charge shall be made by state party pursuant to these regulations for the following measures for the protection of public health, appropriate isolation or quarantine requirements for travelers. Now, that article goes on, and we, the Secretariat, have, in the course of this pandemic, gotten lots of questions about how do you interpret Article 40? It seems to say that the travelers shouldn't be presented with a bill. And if they are, there's all sorts of other conditions on that. The answer is the Secretariat, and this is one of the great things about being the Secretariat, we can avoid questions because the answer is how you interpret that depends on how member states interpret it. It depends, they are the ultimate arbiters of what this means. But as I said, it is, I won't go over the whole thing. It's a complex article. There are caveats and exceptions and conditions to this charge issue. But I hope it gives you a sense in this limited amount of time that this international instrument, this legally binding international instrument, is both complex and very specific. And it is ultimately, its implementation is up to member states. The Secretariat has certain powers with respect to this instrument, which I think will also be of interest to you, powers with respect to member states that give us a right to ask the authorities of member states for information, for example, particularly when it comes to things like travel restrictions or recommendations of the emergency committee. So if the WHO issues recommendations that are based on the advice of this emergency committee established by the IHR. And those recommendations say, for example, we don't recommend closing of borders, which is not hard to imagine because that's frankly what they said and what the article I just showed you said. Countries, because it is a recommendation, literally that's the word, a temporary recommendation, and not a law, countries have the discretion to go beyond that. To even though WHO recommends no travel, no border closures, to close their borders. But if they take that step, which is called under these rules an additional measure, then countries have an obligation to report to WHO as to why they took that step and what were the bona fides of taking that step. And then we, the Secretariat, this is all under an article called Article 43, can get back to the state and say, could you send us more information? Or we could say, could you reconsider that measure? Because according to this independent emergency committee composed of independent experts, this is not a proportionate response to the health threat. But ultimately, that's the extent of WHO's authority here, to ask the state for more information and ask them to reconsider measures that might go beyond what this IHR emergency committee is recommending through the Director General. And so this leads to my final point, the gaps part that Larry asked me to address. So what happens when there's a disagreement between the Secretariat and a member state, or between member states among each other? What happens when South Africa, for example, might say, we reported Omicron. Omicron was already in other places, and yet there were travel restrictions imposed on travelers leaving our country. How does that get resolved? And the answer is this is a weakness in the IHR. There is a dispute settlement mechanism in the IHR. This is in Article 56, but essentially what it does is it kicks the issue to the World Health Assembly, which is a political body composed of all 194 member states of the organization. And even with that very political sort of arrangement, no state has done this. No state has availed themselves of this dispute settlement mechanism in the IHR. There is, of course, nothing equivalent to an individual right of petition under the international health regulations. You see that in some areas of human rights law, doesn't exist in the IHR, which is only to say that if a traveler feels that he's being charged unfairly, that individial has no recourse under the IHRs in an international sense. I hope this gives you some sense. I don't want to speak too long about this because I want to see whether I'm in the ballpark for what you want to know. This area is, I think, given what you're looking at, and I'm sure my colleague Stephen Hoffman, whose scholarship in this area is extraordinary, will agree that it's a fascinating area. It's also an area that's very dynamic. There's a lot of discussion about changing this. How can this be improved? I think it's fair to say that with respect to these basic overarching things, the human right to dignity, these issues, there is an expectation, and this goes to an overarching concept in international law, pacta sunt servanda, that the parties will fulfill this in good faith. Whether they have done so in this pandemic is a question that only the parties can answer, and commentators. But that's I think where I'll stop. And thanks very much. And I appreciate again this opportunity.
Thank you. So Larry, you had a question?
Yeah, I do. Well, first of all, Steve, that was just superb and exactly what we needed to hear. And I saw you there in the WHO lobby, but I don't think you're actually really there now. I had a little bit of a heart pang because it's been so long since I've been to that WHO shop on one side of you. Anyway, thanks so much. I have one small question and then one just larger one. The smaller one is that you mentioned the duty to report, and that gives WHO Secretariat through you the ability to ask for more information or to ask the state to reconsider. What if states don't report and have a lot not reported? That's the first thing. And the second thing is that to the extent you're at liberty to do so, Steve, but only to the extent, are you able to inform us about the IHR targeted amendments process that the US is leading? And that's particularly important to us since we're a US-based scientific committee.
Sure, thanks. So Yeah, Larry, thanks very much for that. So again, Larry's referring to what the reporting under Article 43, I believe, because there's all sorts of other reporting requirements which are very controversial, whether states report an outbreak when they should and as quickly as they should in the manner that they should.
Yeah.
Whole another issue, different, I think, than the sort of arena you're in. But on the reporting of additional measures, Larry, you've pointed to another sort of gap, which is we don't have, the Secretariat isn't gifted with a systematic reporting mechanism by member states to do that. We can observe through our over 150 country offices, we can observe through media reports, and this has happened in the past, without going into details of who and when, if we see countries taking measures which go beyond what WHO has recommended, we contact them. We do that through the IHR National Focal Point. We say we've become aware of this. Could you let us know what you're doing and why you're doing it? That often happens, but I think it's very important here to underline that unlike many treaties which have a separate financing mechanism, WHO doesn't have a separate, IHRs don't have a separate financing mechanism. So there is a staff that I think would strike you as surprisingly small doing all this. So not only and then there are the countries, Larry, which do report, and and then there's a body of work in assessing those reports and whether they are proportional, and then that exchange getting back. And then there's a question of how we overall report to other member states the work we're doing under this, and whether we, the Secretariat, have the gift, the authority to actually either publicly or to other member states inform about who is doing what. So these are many questions. There's a review committee process for the IHRs. The recent review committee looked in detail at this, and they've prepared a report which is publicly available and gets into a lot of this. But I think it's another area where there are weaknesses in that reporting regime. I would say overall, Larry, that this is part of this is it has to be understood historically, contextually about the IHRs themselves. They were built like generals fight the last war. Diplomats negotiate the last event in their treaties. And the last event for the IHR was SARS. It wasn't a global pandemic on the scale. No one anticipated something of this scale and magnitude and scope. And I think, speaking personally, there's a case to be made that the IHRs were not designed for the kind of pandemic we're seeing now, which brings us to the question of the amendments that Larry mentioned. So the US is proposing a raft of amendments called they're calling them targeted amendments for the consideration of the other 193 member states who will participate in their consideration. They're proposing the amendments to be adopted in May of 2022, just 4 months from now. Those amendments will be, those proposed amendments will be circulated publicly and this week to all other parties. And then according to how the amendment process is set out, they may or may not be negotiated or even adopted at the next session. It's hard, Larry, to summarize the many amendments the U.S. has made in this area. Probably I'll just give you an example of one, a discrete procedural one. And I would say for the interest of your committee, most of the proposed amendments do not bear on the quarantine and travelers issues. They really concern themselves more with reporting requirements, both in terms of events and in terms of this Article 43 issue as well. But to give you an example of what's an amendment of an IHR being proposed like, one that I can talk about that was actually recommended by or considered by the review committee was the amendment procedure itself. So there is an amendment procedure in IHR which says that once the Health Assembly agrees an amendment, then everyone, the whole world has to wait 2 years before that amendment comes into force. Now, many countries, particularly the US, which put this forward, says, well, that's too long. If the IHRs are going to be truly an agile instrument that is capable of being future-proofed, there needs to be a shorter entry into force timeframe for any amendments, say 6 months. And so that is one of the proposed amendments. So the amendments go from this sort of very small procedural thing that are being proposed to something much bigger. That said, there's a lot of controversy among member states on whether the way forward should include, as a first step, amending the IHR, or many of you will have heard, of course, about the discussions which have really got underway about the possibility of a pandemic treaty, also under the WHO Constitution, that would be more of an omnibus approach to this situation. So I'll stop there. Thanks.
Stephen, let me just ask one question before he answers your other question, Larry. If the U.S. was to not report, you folks picked it up, who do you call? Who from WHO calls where in the U.S.? Is it CDC? Is it HHS? Is it your representative on the board? Who do you call it
There's an office in HHS, and it's the U.S. national focal point. And it is actually staffed 7/24 through the HHS sort of emergency staffing room. But there's a team in the U.S., which is not the case in all other countries, as you might imagine. There's a team that follows this under this requirement that every country establish a national focal point for IHR implementation. And that's again, that's a 7/24. So that contact is straightforward. But then we will, because we have this engagement with every one of our member states, we will often, if there are additional or technical aspects, make other contacts, always keeping the national focal point informed. But those contacts can include the local missions in Geneva, or in the case of where we have country offices, the health ministry, where we have our WHO representatives.
Larry, go ahead for your next question. I know we got a hard stop for this.
Yeah, we do. I mean, I think all I wanted to do was thank Steve. I just thought that was a superb tour de force, and we could listen to you forever, but I don't want to monopolize your time.
Well, thank you very much. And I hope I haven't stepped on Stephen Hoffman's time too badly. And Stephen, I'm really looking forward to hearing you. So thank you very, very much.
Steve.
Great. George, do you want me to go ahead?
Yes, please.
Perfect. Yeah. So first, a big thanks to the committee, the chair, for inviting Mathieu and I to present today. I'm really excited about this opportunity. Just by way of background, so I'm a professor of global health, law, and political science at York University in Toronto, Canada, where I direct the Global Strategy Lab. I also hold the Data Lid Distinguished Chair in Global Governance and Legal Epidemiology. I'll be sharing this presentation with my colleague Mathieu Poirier, who's an assistant professor of social epidemiology, the associate director of the Global Strategy Lab, and recently appointed a York Research Chair in Global Health Equity. I mention all this just to emphasize that our lab, we really specialize in taking an interdisciplinary approach, looking at various strategies that address health threats that transcend national borders. A lot of our focus, therefore, has been on things like pandemics, antimicrobial resistance, other issues. I'm just going to share my slides, and I will hope that everyone is able to see them. Can I just get a confirmation that?
Yep, we got it.
Excellent. So I think our presentation follows beautifully from the one that Alan and Karen presented about what was done in Australia around several different border control measures. And then, of course, following beautifully, Steve, from your great presentation about the international health regulations. I wanted to emphasize, though, we are going to talk narrowly about border closures. We're not going to talk about quarantine. We're not talking about testing, either pre-travel or post-arrival. We're talking about border closures. And we will, though, address it. First, the law, the epidemiology, and politics. And more specifically, what we're referring to is the various different ways that countries around the world closed its borders during this pandemic in ways that were unprecedented. The first border closure was a targeted border closure on January 23rd, 2020, from Taiwan, restricting travel, incoming travel from China. But as you'll see over these next few slides, A month later, there were actually 38 countries that implemented targeted border closures, mostly against travel from China. But it didn't stop there. 1 month after that, the number that had targeted border closures against China and some other countries were 51 countries. But importantly, and very unexpectedly, 115 countries by this date had enacted total border closures, whereby they mostly didn't allow anyone to come in who is not a citizen into their countries. And then just one more date, by the 1st of May, 95% of the world's population lived in a country that had enacted either a targeted or total border closure. So what we're planning to do today, very briefly, is talk about the law of border closures, although Steve's done most of my work for me. Thank you, Steve. I will pass it to Mathieu to talk about the epidemiology of border closures. He'll present a study that we've been doing at our lab. Be back to me to talk about then the politics of border closures, and then we'll end with some key messages for US border policy. So very briefly about the law of border closure, just because I won't repeat what Steve said, and also your committee has the world's most eminent global health law scholar, of course, Larry Gostin, so your committee doesn't need too much advice on law. I will, though, just emphasize the article that Steve referred to in his presentation, Article 43. This is the article that does not allow countries to enact additional health measures unless those measures are supported by science, they're proportionate to the risks involved, and respectful of human rights. Essentially, what that means is this article, which, as Steve mentioned, it's a legally binding part of a legally binding instrument, means that most COVID-19 border closures have been illegal. And to be a little more precise just about it, but not to go into detail, I'll just highlight that, for example, Article 43.2 of the National Health Regulations says that countries cannot implement additional health measures just as a precaution. It has to be grounded in science or based on a recommendation from WHO. That did not happen in this case. The science before the COVID-19 pandemic mostly pointed against travel restrictions like this, although Mathieu in his presentation will update that for you. And also WHO recommended against it. Second, if you look at Article 43.1, it indicates that any additional health measures shall not be more restrictive of international traffic and not more invasive or intrusive than reasonably available alternatives. What we saw in COVID-19 was that many countries, if not most countries, actually overlooked some other reasonably available, less restrictive alternatives that could have offered equal levels of protection, whether that's about mandatory quarantine, whether pre or post testing and such. And then third, any of these measures have to be respectful of human rights. Yet it's clear from many of the statements from some political leaders in some countries that border closures were not only, or and sometimes not at all, motivated by their potential effectiveness or based on public health principles, but rather a lot of the language that political leaders used when implementing them were really tinged with racism and xenophobia. And so I know Steve said that he, as a WHO official, can't say that these are illegal and it's for member states to decide, but it's very clear to any international law scholar, any international lawyer like myself, that most countries violated their international legal obligations under the IHR during this time. That being said, the big question, do they work? And for that, let me pass it to my colleague, Mathieu, who will walk you through that. Mathieu.
All right, thank you very much. Pleasure to be here. I'm going to start by going through the epidemiology of border closures. And like Stephen said, it is certainly not an on-off switch. There are different strategies that were implemented around the world. The first kind of strategy that we saw was just no border closure at all. There were a few countries that did this, not many. I have here Nicaragua as one example. And I'll also point out that we examined border closures in terms of two parameters: the percentage of the world population that was targeted by these closures, and the percentage of known global cases at that point in time that were targeted. So these are evolving measures over time. So another kind of border closure that was implemented was a total border closure. Obviously, this restricts travel from all countries, so the entire world is targeted and all the known global cases are targeted as well, by definition. There were two strategies here. One was an early total closure. I have Slovakia as one example in early to mid-March. and a later total border closure. Here we have an example of Mozambique that waited until almost June to put in place their total border closure. Things get a little bit more complicated when we look at targeted border closures. So the first example I have here is South Korea, which implemented a targeted closure against China. And at that point in time, in early February, that constituted the vast majority of the world's known global cases. But that really quickly declined over time. And by April, it was a very small minority of the known global cases. Another kind of targeted closure is to target many different countries. Here we have Sweden as an example. So they targeted most of the world, but had exceptions for quite a few European countries. And since these European countries were heavily affected at the time, really they were only targeting a little over half of the world's known cases, although that did increase over time. And finally, another example is Japan, which had a strategy of continual adjustment. Again, they started with China, but as the proportion of known cases decreased over time, they added countries to the list, which kept on gradually adding to the percentage of known cases targeted. So let's take a look at the US and what that looked like. Here we have the different closures that were put in place, first against China, and then followed by Iran, the Schengen area, UK and Ireland, followed by Brazil. And just have some contextual information here for what was happening in the world. But you'll see that the percentage of known global cases decreased quite quickly over the month of February, and again after March, and to the point that probably less than half of known cases were targeted, although we do have to emphasize that these are certainly uncertain measures. So that's the situation. And as a lab, we tried to get to the quite important question of do these border closures actually work? So this is an unpublished study. I am unfortunately not able to share our full results. When it is published, we will certainly share everything. And please do get in touch with us if you have any questions we can address immediately. But our approach was to use real world data, so non-modeled data. And we applied quasi-experimental methods, interrupted time series analysis, coarse and exact matching, which are some of the strongest methods that we can use in a situation where a randomized controlled trial is not possible. And we tried to estimate the effect of both national border closures on national and global transmission of COVID-19 in the first wave of the pandemic, with the effective reproduction number as the outcome. So did they work? Well, our findings indicate that early and extensive closures can work to reduce transmission of COVID-19 within countries. This is true of both total closures and to a lesser extent targeted closures. Although I have to emphasize that country level results were highly uncertain, with some countries seeing an increase in transmission after border closures, some seeing no effect, and others seeing a reduction. And there were actually quite few factors that could predict whether or not a closure would be successful. But two of the factors that were associated were the date of implementation. So late implementation of border closures did seem to reduce the effectiveness of both total and targeted closures. This is consistent with emerging literature that is supporting early action. And I have here cited a living systematic review. And also the proportion of global population targeted appeared to be more important than the percentage of known COVID-19 cases targeted. And this just illustrates that we're operating in a situation of extreme uncertainty about the distribution of cases, and essentially says that targeted closures that were so extensive that they essentially resembled a total closure appeared to be the most effective. And so those are the results for the domestic transmission of COVID-19. But we also wanted to look at whether all of these closures together that were quite concomitant, they're happening at the same time, whether they had an effect on global transmission. And according to our study, there was no effect on February 5th after there was a rush of targeted closures that were put in place. However, after March 19th, 2020, when many total border closures were put in place, there was a statistically significant reduction in global transmission. And I'll wrap up my section for now by just saying that obviously we're operating under extreme limitations with this study, but we did conduct hundreds of robustness sensitivity checks, and it produced quite consistent results. And to emphasize that these results are new and really run against much of the evidence that existed before the pandemic. And so the question that remains is why countries put these closures in place.
Thank you for that. I'll take the mic again and just emphasize that because, as Mathieu mentioned, the science before this pandemic really pointed against border closures. Yet when you think of the different various measures that countries around the world adopted during this pandemic, one of the most popular was a border closure, whether targeted or total, whether early or late, as Mathieu described. So why is that, and how might that influence US border policy going forward? So first, just to, and this is the slide I'll use to show this, is that while most of these closures were illegal, while most people had no idea, most countries didn't know whether they were going to work or not, they are good politics at different times for different countries. Specifically, border closures can help countries divert blame to foreign actors and factors away from domestic things, such as, for example, underinvestment in public health infrastructure. Second, border closures are perceived to be easier and less expensive to enact than alternatives, although that's definitely, now that we have experience with that, that's definitely not the case. Third, it can give an appearance of thoroughness. And so for a political leader that wants to be able to show citizens that they're doing everything they can, the fact that it's at the border, it's a frontier, it helps signal that comprehensiveness and certainly messages that way. Fourth is that through public opinion polls, we know in many societies, citizens feel that these are a good thing or believe they are. Fifth, because the border is so associated with security, and because political leaders very often find it can be helpful to sort of wrap themselves in a flag of national security, by closing a border and framing it in that way, it creates an opportunity for political leaders to be seen as champions of national security. And then finally, just to flag, this kind of bordering and making use of frontiers in this kind of way fits in with longer term practices of border orientation. By that, what I mean is this is one of the ways that countries really assert their sovereignty and demonstrate to their own citizens around who is in control and who needs to be followed and such. So with that, though, let me just very quickly go, because we're almost at time, which is just ending with some key messages for US border policy. The first is just to summarize sort of everything that Mathieu and I said up until now. It's really 3 points. The first is to emphasize most border closures that we saw during COVID-19 were illegal under the national health regulations for different reasons. But the main reason would be, or for most countries, the reason would be that there were less restrictive alternatives that were available and that those countries skipped over or did not implement in favor of this more restrictive alternative. Second, as Mathieu highlighted, early and extensive border closures can reduce transmission, yet it was only a near complete closure of global borders that slowed the COVID-19 pandemic. And in that respect, other public health measures provide more reliable protection. And then third, countries primarily close borders because it's good politics. And I can say that because they're not doing it because it's legally obligated, because in fact, it's mostly the opposite. And in the COVID-19 pandemic, they didn't do it because of evidence of effectiveness, because most evidence before the pandemic actually pointed against effectiveness. In that respect, a smart border policy needs to consider the constraints that political leaders face and what they're actually willing to do when and in what circumstance. So for a last slide, here would be sort of the 3 recommendations that Mathieu and I would offer based on our research. The first is that even though they can be effective in particular contexts, we believe that the US is unlikely able to make good use of border closures as part of its infectious disease and pandemic policies. The reason for that is that closures are most effective when implemented early, yet the political will for them mostly comes after it's already too late. And indeed, the types of closures that are more politically acceptable, like targeted border closures, as Mathieu highlighted, they are not going to slow, or at least in COVID-19, they did not slow the pandemic. It was only when total border closures adopted by more countries that there was a slowing. And once there is political will for border closures, then those closures seem to be primarily designed, and we've seen this in countries around the world, they seem primarily designed to meet political goals rather than being designed to meet epidemiologic needs or legal requirements. The second recommendation is that the US should never enact a targeted border closure, unless, of course, the World Health Organization recommends it. And the reason for that is that targeted closures, they're less effective. They disincentivize other countries from reporting new outbreaks, right? Because what country would want to report a new outbreak or a new variant if they're going to be slapped with the trade or travel restriction? And third, they're almost always, because of that, going to be illegal. And then the third recommendation then is that, which I think is maybe one of the most important things the US can do, which is to better support the World Health Organization to do all of its functions, but also to coordinate global border policies. And that's because the usefulness of national border closures depends on what other countries do. And WHO is the only organization with the legal mandates and the competence to lead that kind of effort. So with that, just a big thank you again for this opportunity. Looking forward to answering any questions that you might have.
I think we can take two quick questions. One is, can you differentiate between a border closure and a travel ban?
So a travel ban, it could be the same thing. I mean, some countries have just asked their citizens not to travel. So Mathieu and I are both based in Canada. Currently, the government of Canada has given an advisory against travel. Some people use the word travel ban. So of course, if you're a federal civil servant, that is a travel ban because you're not allowed that government as part of your employment, but it's not a border closure. So there are still, you can still travel across the, for example, US-Canada border. That would be the difference there.
And we're really getting crunched for time. So I think what we might do is, if we have some other questions, we can maybe send them in writing. Stephen, if you were available to answer those, if we send those to you. Or
of course.
We can also ask Stephen maybe to come back if we need to get some more questions than his colleague.
Yep, happy to help in that way. Yeah.
All right. With that, let me, because I do need to unfortunately move the agenda along. Let me thank you very much for that presentation. And